Welcome to this educational activity in which Drs. David Buther and Michael Wexler from National Jewish Health offer insights on important components of asthma management, such as phenotyping patients, individualizing therapy, and improving medication compliance. In addition, one of Dr. Wexler's patients, Lori, shares the story of her search for the optimal management plan in the face of recurring symptoms and steroid side effects that greatly interfered with her life.
Hi, my name is Lori, and I'm here to talk to you today about my experience with asthma. This journey started for me when I was 16 years old. I was a very active high school student. I sang in the choir. I had been a dancer since I was very young in grade school. Dancing was an extremely important part of my life. I was on the dance team in high school, and we were very competitive, traveled for competitions, was very physically involved. One night I was sitting with my friends watching a movie in a theater, and I suddenly had this terrible cough, and I coughed up a hard mucus plug, and this was something that had never happened before. In the weeks after, I started experiencing shortness of breath quite a bit. When you'd hear me breathe, I sounded like what my family would say sounded like an orchestra or out-of-tune symphony. With this being so new, I was panicking. My coughing symptoms were so extreme, I couldn't really function. Even going up flights of stairs or any kind of movement other than a nice, slow walk was difficult. At first, I started sitting out of dance team practice, and people were confused, as was I, about what was going on. I ended up having to quit the team altogether. I didn't try out the next year. This was really tough for me because I can't even tell you how much I loved dancing and performing, and it was a really big deal in my town, the football games, halftime dance team performances, traveling for competitions. And being involved in choir, with singing, I had a really hard time with breathing exercises, just the prepping for the singing. We were also very pretty big, heavily in the community with events. We sang at the governor's mansion. We sang at various events in our town. So I had to stop that too. My life changed very quickly and very drastically. I had to stop doing everything I loved to be a part of. I was in and out of appointments. I missed school and events frequently because appointments were so far away from our smaller town. I would often have to drive 2 hours to Seattle, dealing with traffic in and out. I was hospitalized at least once or twice for what the doctor thought was pneumonia, and doctors were trying to help, but I was still sick. They were just naming it this severe asthma and not really knowing what to do with it. I had seen my family doctor and pulmonologists, as well as a rheumatologist, ENT doctor, otologist, allergist, infectious disease specialist, and hematologist. I have had numerous chest x-rays, countless lung function tests, CT scans, a few echocardiograms, blood cultures, allergy tests, stool tests for parasites, numerous lab studies, skin biopsies, and a bronchoscopy with biopsies. I have also had a bone marrow biopsy and bone density studies. I have had ear tubes, both temporary, then permanent ear tubes, and aggressive sinus surgery. Doctors continued to think that I had allergies because of the sinus issues I had. And then come to find, after allergy testing, it wasn't allergies, but it was my eosinophil levels, this white blood cell count that were just through the roof. I felt like a guinea pig. Every time I'd go back to the doctors with these symptoms that weren't being well controlled, they would say, try this inhaler, try that medication. Oh, it must be allergies. Oh, it's asthma. Let's combine this with that. And I never felt much better. Over the years, I have been on 2 different inhaled steroids, 2 different combinations of inhaled steroid and bronchodilator, rescue bronchodilators, nebulized treatments, a leukotriene modifier, antihistamines, intranasal steroids, and even immunosuppressants. Eventually, the pulmonologist I was seeing in Olympia put me on oral prednisone because my symptoms were so severe. The prednisone helped, but I was taking it on and off for several years, 10 years. Being on prednisone was hard. It started at extremely high doses, sometimes up to 80 milligrams per day. I'd gained a significant amount of weight. My face became very round and puffy. My hair started thinning and breaking, falling out, which I understand is yet another side of the steroid, prednisone, along with bone thinning affecting different organs. We were experimenting with different doses of prednisone for years, and every time I went to see the pulmonologist, it was just, maybe we can talk about tapering down. We shouldn't have you on this much, not this much prednisone, but, oh, you're doing bad again, we better get you on a higher dose. A lot of back and forth. And doctors would say, I'm so sorry that you're on this drug, but at least it works. So I was really feeling like a mechanical robot, something going through all this testing. And what actually happened was that the pulmonologist I was seeing in Olympia, as he aged, he eventually passed away. So I started seeing a new pulmonologist in Olympia, Dr. Redman, in my early 20s. And this new doctor, he was really the one that saw my condition and being on prednisone with a new lens, with a new perspective. And he started saying, we really need to figure this out. So he took a really solution-oriented approach and just said, we can't keep you on prednisone. This has been too long. You can't continue. Of course, there were concerns about my bones thinning, the prednisone wearing at my different organs, and just overall the way it was treating my body. And that was the first person who I felt like really was taking a concern of my quality of life and what this would look like long term. And that was good to hear, having a new perspective, but it also was scary. It was frightening. What would my life look like long term if I didn't find treatment that worked? So my aunt, who is also my godmother, who I'm very close with and is here in the audience today, she supported me through this journey, she and her family. They live here in Denver. So during this whole journey and not feeling well, nothing helping, my family in Denver was just so encouraging to start looking at what might be going on here in Denver at National Jewish Health. So as I was just continuing to be sick, feeling worse, and entering my early to almost mid-20s, everybody was thinking, there's got to be something that comes along for Lori. And in preparing for this, my mom actually shared that the last specialist I saw, who was a hematologist, called after all this lab work, and knowing my history of specialist seeing, just told her that you have to hope that there is a study or treatment coming out, otherwise there's nothing we can do. And my mom, being a very strong person and able to kind of hide her emotion, just told me recently that she just broke down in the car, pulled over, and lost it. So my family caught wind of some things that might be going on at National Jewish, and long story short, got connected with Dr. Wexler, who was looking at treatment specifically for what I was going through with my eosinophil count. And when my family approached me about this, it was a very busy time. I was getting my master's degree in counseling psychology. I was working full-time as a social worker in nursing facilities. So thinking about going to be a participant in a drug study so many miles away sounded extremely overwhelming. And I knew that I would have to fly to Denver once a month. While it was great to think about seeing my family so often, I know that it was going to be a burden, really, as far as my schedule goes. And I didn't know if I would be taking the placebo or the drug, so I knew that walking into this would be questionable as to how I would feel throughout the drug study. So I went kind of back and forth for a couple of weeks, And I finally came to the point where I realized, having a new family of my own, I had just gotten married and I was 23, 24, and I just realized that this decision to partake in this study is not just about me, but about my family and my quality of life, and it was just bigger than what I wanted at that time. So the decision to do this study was going to change things for me, for my family in the long term, and I decided to dive in. And I entered this study when I was about 25 years old, visiting National Jewish, where I then met Dr. Wexler. And I would say about halfway into the study, I was hoping I was not on the actual drug because I wasn't seeing any changes. But I stuck with it, and after the blinded phase of the study, Dr. Wexler connected me with someone in the Bellevue, Seattle area where I could be treated locally with the actual drug. And that was when I started noticing a huge change because, come to find, I was taking the placebo during the first phase of the study. And this was a very interesting time because although I was feeling better, I was having a hard time mentally. It was sort of a disconnect between my body feeling better, but my mind still stuck where it was years ago, thinking I can't do this, seeing an incline of a hill or stairs. But eventually, I would say just in these last few months, I've really started embracing it. I wanted to see what I could do, like walking uphill without a problem, running around with our dogs. I even started going to the gym a few months ago. So working out gets easier every time I go. So I go a few times a week, but I knew I wanted to start slow. And every time I made it through an exercise, I was just amazed, blown away, really, just incredible. So I have had less coughing, less wheezing, less shortness of breath. It really opened up my sinuses more, although I've been fighting a cold this last week. I have been so amazed at all the things I can actually smell now, which has been nice, but sometimes not so nice. A few weeks ago, I was cooking dinner and I had raw meat, and I had to bring it to my husband to ask him if this is what this really smells like, if this is normal. I didn't know how things were supposed to smell after all these years. So there really have been so many changes, and looking back now on what I couldn't do and what I could do now, sometimes I feel like this is entirely really a new identity. I'm a new person. So I have been on the anti-interleukin-5 therapy along with inhaled treatments almost going on 1.5 years now, and I have not touched prednisone in that time, over 1 year. Once I was able to stop taking prednisone, I very quickly shed 10 pounds without changing what I was doing, still eating the same and not exercising at that time. I also have not had to use a rescue inhaler in years. I've had family and friends say that I look much more relaxed and comfortable, and that I'm looking and sounding better. These things are still hard to believe. In terms of my job, I currently work in private practice, so I create my own schedule, and I have an incredible boss. So I have the flexibility to go and receive my injections in Seattle when I can. So the next step in my journey moving forward will be thinking about starting a family. As of right now, they don't have the data in pregnant women to make any conclusions regarding the safety of this treatment. But I will keep continuing to take things day by day. I'm making a list of pros and cons of staying on the drug while pregnant or coming off of it. So it's a very conflicting position to be in. But all in all, after so many years of battling this disease, I'm just so completely amazed by what I can do by being on this drug and my quality of life. It truly has changed my life.
Well, these are exciting times in the management of asthma. We're developing new therapies, we're getting a good understanding of the disease, and I think we're having an impact. We heard Lori's story, and Lori's story, I think, is a great example of where we are in asthma management. It's an exciting one. We've evolved from an approach that was one size fits all. We used to think that everyone had the same type of asthma, that your asthma was the same as your asthma, and your asthma was the same as your asthma, and everyone who had asthma had the same type of disease. In the last several years, we've started to recognize that asthma isn't one disease. Asthma is a very heterogeneous disease. There are different patient characteristics. Each patient has a different phenotype. What's a phenotype? Phenotype's an observable characteristic. You can be tall, you can be short, you can be fat, you can be thin, you can be black, you can be white, you can be young or old. Those are all phenotypes. In asthma, you can have any of those. Does it make sense that we treat everyone the same way? On top of that, we start to recognize that there are different kinds of asthma. Some people have allergic asthma, occupational asthma, exercise-induced asthma. There's severe asthma. There's steroid-dependent asthma, exacerbation-prone asthma. These are all different. Patients are different, each one from another. They use medications differently. They have different adherence. They respond differently to therapies. One person responds well to inhaled steroids. Another one may not. One person responds to a bronchodilator. Another may not. We need to recognize these differences, embrace the heterogeneity, and understand the underlying mechanisms that result in those differences. One of the things that we've begun to appreciate is that our patients have different biology, different mechanisms of disease. We're starting to appreciate that patients have different endotypes. What's an endotype? An endotype is a characteristic of the underlying mechanism of disease in that person. It means to say that one person's asthma, the underlying mechanism is one pathway, and another person's asthma has a totally different mechanism. You could have an IL-5-mediated patient, interleukin-4-mediated patient, TSLP-mediated patient. There are all sorts of different pathways that affect different patients with asthma. And one of the challenges that we have as physicians is to recognize which pathway is involved in which patient, which endotype is involved in which patient. We're starting to use biomarkers, markers of disease activity, markers of the mechanisms of the disease. Those biomarkers, for instance, eosinophils in the blood or in the sputum, may predict responsiveness to one therapy over another, but it also describes disease activity based on a mechanism in one person over another. We say someone has eosinophilic asthma or non-eosinophilic asthma. Alternatively, we can identify neutrophils, another kind of white blood cell, and identify higher levels of neutrophils in the blood to identify a more neutrophilic or a less neutrophilic person. Or we can look at exhaled breath and look at nitric oxide levels, which may predict an interleukin-13-mediated pathway of activity. Another one would be looking at IgE, an antibody that we all have that predicts increased propensity to allergies. Those are all different biomarkers that relate to different endotypes. And we're also starting to recognize that the different endotypes may have associations with specific phenotypes. So for instance, we're now thinking of type 2 inflammation, Th2 inflammation, and non-Th2 inflammation. Th2 inflammation is associated with different cytokines, interleukin-4, interleukin-5, interleukin-13. And non-Th2 pathways, those patients may not have any of those biomarkers like eosinophils or IgE levels or nitric oxide levels associated with Th2 pathways. But those patients may also differentiate themselves based on specific characteristics. For instance, Th2 inflammation may be associated with allergies from early on in life, may be associated with good response to inhaled corticosteroids. Non-Th2 asthma is associated oftentimes with obesity, with smoking and asthma, with lack of response to steroids. So we're utilizing the endotypes, the phenotypes, to try to get a better understanding of which patient has what type of asthma so we can treat them appropriately. We've transitioned from a one-size-fits-all approach to a more personalized approach. And the way we're doing that is after we diagnose a person with asthma, we make sure it's asthma, make sure they have no other complicating or mitigating factors. We then start to characterize the subtype. What's the person's phenotype? Is he older and may not respond as well to inhaled corticosteroids? Does he have allergic asthma and may respond better to anti-IgE therapy? And based on our understanding of those pathways currently, we can use new therapies that target those specific pathways to have a big effect on our patients. It's fortunate that our understanding of the mechanism of disease is coinciding with a boom in development of novel drugs. We're developing monoclonal antibodies that target specific pathways. Almasmab was the first biologic for the management of asthma. It paved the way for all the other biologics down the road. Almasmab is a monoclonal antibody that binds and targets IgE. Almasmab is approved for the management of patients who have severe uncontrolled asthma with an allergic phenotype. It's a biologic that is administered every 2 to 4 weeks. It's dosed based on IgE levels and body weight. And it's been shown to be safe and effective. And when it first came out, it was a game changer. It offered a new therapy for our patients with asthma. In several studies, it's been shown to improve asthma control. It's been shown to improve quality of life. It's been shown to reduce exacerbations, to reduce hospitalizations. At first it was approved only in adults, but now it's approved in children as well. It's been shown to decrease colds in children. And as we've started to look at endotypes and mechanisms of disease, we start to recognize that we can even identify those who respond better based on specific biomarkers. Patients with higher nitric oxide, patients with higher eosinophil counts, for instance. Those patients tend to respond better to Almasmab than those who don't have those biomarkers. Importantly, Almasmab has also been shown to reduce the use of inhaled steroids and systemic steroids. It's been very effective and a tremendous drug for our patients. But there were some non-responders. Some patients didn't respond because we didn't recognize that one size doesn't fit all, even with the biologics. And that's where the newer anti-IL-5 therapies come along. Just in the last few years, we've had development and approval by the FDA of 3 new therapies that target interleukin-5: mepolizumab, rezlizumab, and benralizumab. What's IL-5? Interleukin-5 is a cytokine that is involved in eosinophilic maturation, eosinophilic proliferation, eosinophil recruitment, eosinophil activation, and it even is involved in eosinophil survival. Knowing that the eosinophil can cause inflammation by release of its granular proteins, eosinophilic cationic protein, eosinophil-derived neurotoxin, major basic protein, amongst others, those substances all cause inflammation, and higher eosinophil counts and more eosinophilic inflammation is associated with more hospitalizations and more exacerbations. If we can target the eosinophil by blocking IL-5 or its receptor, then we can have a significant impact in patients with eosinophilic asthma. Now, we know that about 50% of patients with severe asthma have higher levels of eosinophils. And so those are the patients that we want to target with these therapies. Mepolizumab was the first of these therapies to be approved. It's given subcutaneously once a month, 100 milligrams monthly, in patients who have severe asthma with eosinophilia. It's been shown to decrease exacerbations, including those requiring hospitalization or emergency room. It's been shown to improve lung function. It's been shown to improve asthma control. And most importantly for our patients, it's had a significant impact on quality of life. It's had a significant impact on reduction in oral corticosteroid use. It's an effective therapy, and it too has been a game changer. It has resulted in significant benefits for our patients. Another anti-IL-5 therapy that was approved was Rezos. This was approved in the spring of 2016. And it's administered intravenously to our patients based on body weight. And several studies have now been published demonstrating its efficacy in terms of reducing asthma exacerbations, including those requiring hospitalization and emergency room visits, as well as exacerbations requiring oral corticosteroids. Rezos has been shown to improve lung function. Those improvements in lung function happen very early on, and they're sustained. And it's been shown to improve quality of life, symptoms. The newest drug on the block is benralizumab. And that's a drug that binds the IL-5 receptor and has its own efficacy in patients with eosinophilic asthma. It, too, has been shown to reduce exacerbations. It's been shown to improve lung function. It's been shown to reduce steroid dosing. And it's had a significant impact on quality of life. All three of these drugs have been shown to be not just effective, but also quite safe. So we have all these drugs now. How do we decide which drug to give which patient? The answer is to really look at the patient characteristics. What is the phenotype of that patient? What is the endotype of that patient? Are there any associated biomarkers? And you can perhaps create an algorithm that will allow us to choose one therapy versus another. So for instance, let's say you have a patient who's got allergic asthma but has low eosinophil counts. That person would seem to be a good candidate for anti-IgE therapy. Now, if the person isn't very allergic but has high eosinophils, seems like a perfectly good candidate to give anti-IL-5 therapy. What if the person has both an allergic phenotype as well as eosinophilia? In those, we don't have any good head-to-head data as of yet. And perhaps you could give either one. You could try one, doesn't work, try another one. We're right now at a time in our management of asthma where we're still trying to get a good understanding of how these drugs work. We don't have good head-to-head studies as of yet, but we're working on it. We don't have the best biomarkers, but we're working on it. In the next few years, we're also going to have other therapies. So what do we do for the patients who don't respond to anti-IL-5 or anti-IgE, or who don't have allergic asthma, who don't have eosinophilic asthma? What do we do for them? Well, we currently have an option to use bronchial thermoplasty. We can give those patients systemic corticosteroids. Perhaps we can treat those patients with antibiotics. But fortunately, there's other new therapies coming down the road. Anti-IL-4 and 13, dupilumab, that's been shown to reduce asthma exacerbations, improve lung function, not approved yet. Perhaps we're going to be using other targeted therapies that perhaps target interleukin 33, TSLP, interleukin 6, interleukin 17. So when I think about Laurie's case, I think of a few things. I think of what it would have been like to be Laurie 5-10 years ago when we didn't have options. I think about what it would be like to have lived like that and now to not live like that. To be able to breathe again, to be able to exercise again, and to be freed from steroids. It would be great to live in a world where we didn't have the side effects of steroids. When I think of Laurie's case, I think of how fortunate we are to have the capacity to offer new therapies. We're now recognizing how complicated asthma is, that it's a heterogeneous disease. We have new therapies that we hope will continue to alleviate the burden of oral steroid use as we've seen in Lori. These are exciting times, and I'm excited for the future for our patients with asthma. Thank you very much.
Before considering targeted treatment for patients with asthma, it's important to start with the basics. We want to conduct a thorough assessment to ensure that the lack of disease control has not been caused by some other issue. This is the foundation of asthma care before we get into targeted therapy. And I'll give you an example by telling you about a patient named Nate. When I first met Nate, he was 41 years old. He had had asthma for about 10 years, and it started out to be not a big problem, but it gradually became an increasing trouble for him. He moved back to his original home in Colorado 2 years before I saw him from another state. He was brought back by a job transfer. He was very busy with work. He had 2 young children, and he worked long days. The family was very busy, and he really never saw a doctor in the 2 years he was in Colorado. He worked at a sedentary job as a software engineer, but notably he had a couple of activities he was quite passionate about. First, he was an avid mountain biker. He headed to the mountains all the time. He would ride his bike fairly intensively. He would also sing in his church choir on Sundays, and had been doing that for years. And so both music and mountain biking were very important to Nate, in addition to his family and his work. And for about 7 years after Nate was first diagnosed with asthma, he didn't even use a daily controller agent or see a physician regularly. But despite that, he had weekly symptoms of a dry cough, chest tightness, and chest congestion. And while those symptoms were not severe, they were persistent. And Nate really attributed this to allergies and didn't think too much of it. So when he was starting to get more symptoms, a doctor had prescribed him beclomethasone HFA, 80 micrograms, 2 puffs twice a day. And when he started to take that, these symptoms of cough and shortness of breath that were rather mild seemed to resolve fairly quickly. But he really never liked this medication. You see, the problem is for Nate, he was worried about taking steroid medications. He was concerned that he had developed some hoarseness on the medication, and he really didn't consider his asthma to be a chronic condition. He felt like he was doing quite well, and he felt like he didn't need a daily medication. So because of that, he decided himself to cut back to 1 puff twice a day. And he's also struggled with a little bit of jitteriness and palpitations when he would take his albuterol rescue inhaler. So he was prescribed levalbuterol, which he seemed to tolerate a little bit better. So he would take his levalbuterol before exercise, typically when mountain biking, and that would seem to help reduce symptoms of chest congestion, shortness of breath. But the problem is that he would go out for several hours, and he would find that the albuterol or the levalbuterol would not last long enough. So he found that he had to redose. And like a lot of patients that exercise for a more extended period of time, these short-acting medications do not seem to provide enough relief. He was waking up 2 to 3 times per week, 4 a.m., shortness of breath, cough, having to take his inhaler in the middle of the night. And this required him to go through a few more levalbuterol canisters than he would otherwise, just for pre-treatment with exercise. Overall, Nate was feeling better since starting beclomethasone, and so he had decreased his dose further from 1 puff twice a day to 1 puff just in the morning. 3 months prior to visiting my office, Nate presented with what was a pneumonia, essentially. He went to the local emergency department over a holiday weekend. He had fatigue, he had shortness of breath, he had some new chest discomfort, and a new productive cough that was different than his typical asthma, and an x-ray showed a right lower lobe pneumonia. He was treated with antibiotics, he was treated as an outpatient, he did rather well, he slowly improved over several weeks. But ever since that episode of pneumonia, he's had a persistent new generalized chest discomfort, pain in his left shoulder blade whenever he took a deep breath, and sometimes when he lied down, and really generally felt more short of breath. He started to avoid his mountain biking, he wasn't active, and because of that lack of activity and feeling ill, he gained about 10 pounds over the winter. He wasn't sleeping well, he was struggling at work, and because of these symptoms and because of lack of sleep and all that he had been through, he started to feel mildly depressed. So when I saw him in the clinic, I reviewed his systems and found that he has significant seasonal allergies, typically itchy, watery eyes, sneezy nasal symptoms, scratchy throat, a mildly productive cough, typically in spring and fall. He'd respond to as-needed over-the-counter non-sedating antihistamines. He also had some reflux or heartburn symptoms, which manifested as kind of a burning under his sternum. And it only occurred 1 to 2 times per month where he would take some over-the-counter medication. Now, Nate's a lifelong non-smoker, and he's really quite young and healthy. He works in an office environment. He has no exposures. He doesn't have pets. There's no mold. There's no new thing in the environment that's causing his symptoms to worsen. And he really has no other significant past medical history other than sometimes it's really difficult for him to initially get to sleep at night and the allergic rhinitis. His examination was more or less normal. He's thin, he's not obese, BMI was normal, his throat's clear, his nasal mucous membranes are a little boggy, consistent with allergies, but there wasn't any purulent drainage, and his lung exam was entirely clear to auscultation. As part of his evaluation, we do spirometry in the clinic, and his spirometry showed mild airflow obstruction. So while his vital capacity, or lung volume, was 100% predicted, his FEV1 was 83% predicted, which is in the normal range. But if you do the ratio of the FEV1 to FVC, it was 65%, which is very close to his lower limit of normal of 69%. So when we see this FEV1 FVC ratio mildly reduced, we worry that there's mild airflow obstruction. And that FEV1 of 83%, while in the normal range, might not represent his true normal. And this is a mild hint that perhaps his asthma isn't well controlled. But that, combined with his symptoms, suggests that he really doesn't have good asthma control, does he? He's waking up at night too frequently. He's having too frequent daytime symptoms. And so we talked about increasing his beclomethasone back to 2 puffs twice a day, as that seemed to work for him for asthma control in the past. This time we taught him how to use his device with a spacer. It turns out that he had never been using the beclomethasone with a spacer, and when he approached me with the side effects that he had had with the medication in the past, I told him that with the spacer he may deliver more medicine into his lungs, less in the back of his throat, and perhaps maybe that would reduce his side effects. So we reviewed his inhaler technique, we went over that in detail, and I had him re-demonstrate it back to me that he was using the medication properly. And he did a good job of that. And it seems that he probably wasn't using it as well as he could have. We did some other workup, because when somebody has a pneumonia and somebody has persistent symptoms that fail medication, you worry about a broader alternative diagnosis, particularly in people over 40. So his chest X-ray is really quite unremarkable. He did not have an elevated blood eosinophil count. His IgE was low despite his history of allergic rhinitis, and his bronchial challenge showed a PC20 of 1.36 milligrams per milliliter, which means that he has a fair amount of airway reactivity, and that, in combined with his typical history, really establishes that he has asthma as his primary pulmonary diagnosis, and not something else or something in addition to asthma. So we brought Nate back at 6 weeks, because we wanted to give his medication enough time to work. We wanted to assess how increasing the dose and frequency helped. And his symptoms were improved. He felt like we were making progress, but notably they were not resolved. Certainly he still has exercise-associated symptoms despite pre-treatment. He also has still a mildly reduced FEV1 FVC ratio, so that physiologic abnormality had not resolved. And he still gets chest tightness, sometimes randomly, sometimes in the middle of the night. That had improved in frequency and severity, but it's still there. It hadn't resolved. And that's that new symptom he's had since he had a pneumonia. He wakes up about once per week at night instead of several times per week, so that's an improvement. But because it's still once a week, it's more often than twice a month, and it still meets guidelines as not well controlled. But when I talked to Nate about this, he says, you know, when I wake up, it's probably just because of my allergies. I think my asthma is doing fine. So I was assuming that these symptoms were from Nate's asthma, based on the lung function, based on the frequent nocturnal symptoms. So I decided he needed a step up in his asthma treatment from inhaled corticosteroid monotherapy to combination ICS-LABA therapy. So we chose budesonide formoterol, 160 micrograms, 2 puffs twice daily, again with a spacer. I instructed him on the use of that device, and he demonstrated it back to me. So we brought him back again 2 months later to reassess his control. We hadn't heard from Nate, and he showed up in clinic, and he says, you know, your drug caused me to be really hoarse, and that caused me all sorts of problems. I also developed new headaches that I hadn't had before. So what I did is I cut my medication back to 2 puffs only at night. And I still have hoarseness in the morning, but it tends to resolve by the afternoon. It turns out Nate does a fair amount of work where he gives oral presentations and training, and in the afternoon, for him to have hoarseness really gets in the way of his work. So by cutting the morning dose out, he had better hoarseness in the afternoon for work, and that seemed to help him. The daytime symptoms outside of exercise occur 3 times per week, so he's still not in the well-controlled category. He no longer has the nighttime symptoms, so he gets through the night, but he has more trouble getting to sleep to begin with. And he seems to think that this is related to his new medication, and it may be related to his long-acting beta agonist. He's having more fatigue because he doesn't feel he's sleeping enough, because sometimes it takes him an hour or 2 to get to sleep. I start to get into his habits, like, what are you really doing? And he's working late, his family's busy, oftentimes they eat without him, and then he comes home, puts the kids to bed, and then he eats. And because sometimes he skips lunch, he's starving to death, and he eats a huge meal late at night, and he's tired and exhausted, and he goes to sleep, lies down at least to go to sleep, within 30 minutes of a full stomach. So he's having more reflux at night, burping, belching, heartburn. And one of the other things that's really important is he's not back to mountain biking yet. He still feels like he doesn't have the capacity to do that. And his singing in church has gone away. It turns out that even though to some degree his hoarseness has been helped by cutting back on his medication, in church they're singing in the morning and he can't do that at all. And that's an important part of his life that he really misses. So really a lot of the important things, like with Lori's case, have been taken away from him. So what do we do with Nate? Well, on further investigation, he seems to be fairly irregular about his medication. Not only did he reduce the amount of medication and cut out the morning dose, but sometimes he forgets the evening dose too. The guy's busy, he's tired, has a busy family and work life. And so it's probably 2 times a week he doesn't take anything all day. Despite all this, he's getting enough of this higher dose of medication into him that his spirometry has improved. So we've seen some progress in symptoms. We've seen some improvement in that mild spirometric abnormality, but that's not what we're treating. We're treating Nate and what he can do and not do. So what we did is we started to treat his rhinitis. We gave him behavioral precautions for reflux. He occasionally takes a proton pump inhibitor over the counter, but when he does, he often takes it before bedtime, and I educated him that to take it 30 to 60 minutes before a meal actually allows it to be more effective. We talked about sleep apnea and asthma. He and I agreed that maybe we need to address the nasal drainage, the reflux, and the asthma first, and then reassess where we are with that before going into an expensive sleep study. Nate seems to have a little bit more nocturnal asthma than the average. And in a lot of asthmatics, they have nocturnal symptoms. The keys are don't forget to add the evening dose of controller therapy. Adding long-acting beta agonist is a great strategy for someone that has nocturnal symptoms. But also a lot of these comorbidities can irritate you in the night. Sometimes even a targeted dose of long-acting theophylline late in the afternoon can help with nocturnal asthma, but it can worsen reflux and it's a third-line medication. Nate's exercise-associated symptoms are targeted primarily by pretreatment with a short-acting inhaler, but in individuals that have more long endurance exercise or that's insufficient, we sometimes do have to step up controller therapy to target just those exercise-associated symptoms. And there are non-medication strategies like doing a good warm-up and making sure that you try to reduce cold air exposure through scarves or face masks, etc. So what we did with Nate is we switched him to a different ICS-LABA combination. In some patients on formoterol-containing agents, they get too much jitteriness and insomnia. It typically goes away after taking the medication consistently, but in Nate's case it didn't. So we thought we'd try a different long-acting beta agonist, one that's slower in onset, but similarly effective, containing salmeterol. And that seemed to do the trick for him. We chose an HFA delivery because he had so much hoarseness. Anecdotally, the dry powder inhalers tend to cause a little bit more hoarseness. So we thought, well, let's try this. But really, this is a trial and error kind of approach where you can't predict how someone's going to do. Many patients have knowledge deficits about asthma goals of care, and perhaps I didn't do a good enough job early on with Nate to talk about the goals of therapy being complete control with the least amount of medication possible. And maybe if I had done a better job of that, Nate and I would have been more in sync in terms of what our goals of treatment were and how to approach this. Maintenance treatments like taking your blood pressure medication, you got to do it every day even when you're feeling better. And Nate seemed to get that after some time. You have to go over cost and adverse effects. So the next steps for Nate, we addressed his inhaler technique. Turns out he wasn't really rinsing his mouth well enough. He wasn't always using it properly, even though he demonstrated in the office how well he could use it. We talked about how with HFA delivery devices, you really do need 2 puffs because you don't always get the full dose in that first puff. So it turns out that when he thought fairly intuitively, if 2 puffs is too much, I can go to 1 puff. You can't really do that because you may not be getting any puffs at all. You may be getting a very inconsistent delivery. That's why it's 2 puffs twice a day. Once I explained that, he seemed to get on board with that concept a little bit better. So really, there are a lot of things that influence the decision on delivery device, from patient preference to age. The most simple device to use is a dry powder breath-activated device, but sometimes if they have side effects, the old-fashioned HFA with a spacer can be better. There are soft mist inhalers. So keep mixing this up until you find what works for the individual patient. Now Nate has total control. He's doing really well. He only uses a short-acting levoalbuterol before exercise. He's training for a 50-mile mountain bike race next year. He's no longer depressed. He's doing well at work. He doesn't get the hoarseness anymore despite taking his medication regularly. He's sleeping well. He still has some insomnia, but he feels well rested, and he's really quite successful. Nate was able to eliminate all of his reflux symptoms and get off of that proton pump inhibitor entirely, which is great for long term. So he's very consistent with his controller therapy. His nasal symptoms are still not completely controlled, but they're improved, and they don't bother him very much. So in conclusion, we saw both with Lori and Nate, asthma can significantly interfere with the lives of our patients. Appropriate treatment selection, correct inhaler technique, adherence, management of all of the comorbidities, all of the things are an important foundation. For Nate, that was the key. For Lori, she might have needed a little bit more. But you can't get to the fancy medications and the targeted therapy until you get the basics down. And that can be quite difficult and take some time, as it did for Nate. So thank you very much for tuning in to hear about Nate's journey. I hope you found it interesting, and I hope you can use what you've learned in the care of your own patients with asthma. Thank you.
This is Dr. Wexler. We hope you've enjoyed watching these videos. Now let's begin the question and answer session. There are a few questions that have been typed in. Why don't we go through some of those? You mentioned new medications. Is this available for patients under 18 years of age? So that's a very good question. Two of the newer biologic therapies are approved in children down to age 12 in the case of mepolizumab and benralizumab, and omalizumab is approved down to a younger pediatric age group. And so those options are available for the pediatric age population. The other therapies haven't been shown to be unsafe in asthma or in kids that age, but they just haven't been tested adequately at this point. And I suspect that in the coming years, there will be more pediatric studies that will emerge, will demonstrate efficacy and safety in that patient population, but we need to wait for those studies to come out. The next question is, while on monoclonal antibodies, do you generally step down any corticosteroid dose? I'll take that one. So I think in general, when someone's on monoclonal antibody therapy, one wants to try to de-escalate therapy as much as possible. And what we try to do in our practice is get people to as few inhalers as possible. We try to figure out what's helped and what hasn't helped. And then we will continue to de-escalate therapy. Generally, we keep people on at least a low dose of inhaled steroid and a long-acting beta agonist in addition to the monoclonal antibody. And if the patient is doing well, we could consider either giving the patient a holiday from the monoclonal antibody or discontinuing the controller therapy altogether. But there's no good guidance, and that has not been studied well in the literature. There's been no step down from monoclonal antibody studies done. Another question is how do you address adverse events of the monoclonal antibodies with patients? And related to that, what is your current protocol for IL-5 injections in the office? Do you require shingles vaccine prior to starting the injections? And if so, which age groups do you target? Do you require a wait time in the office following an injection? There's a lot of questions right there. But I think we tend to be pretty open with our patients and give them as much information as we can regarding the safety profiles of these therapies. They are generally safe and well tolerated. We talk about injection site reactions. We talk about the possibility of a more acute hypersensitivity reaction that occurs very infrequently, less than 1% of the time. And then, depending on the specific therapy, we talk to them about other specific potential problems. So one thing that's been highlighted is the issue of herpes zoster. That occurred very infrequently in patients treated with mepolizumab, but particularly in older patients. And so for older patients, we might mention that, and we would give the herpes zoster vaccine, the shingles vaccine, prior to starting therapy. There is actually no specific guidance about when to give it, what age group to give it in, and when to consider it, but we tend to give it in older patients above 50 before they start therapy, just in case this is a real phenomenon. And in terms of requiring patients to wait in the office following an injection, we generally have people wait for the first few visits an hour and a half to 2 hours, and then after 3 visits or so, we have them wait for about an hour. The risk of any kind of severe adverse reaction that happens acutely has been shown to go down after a number of visits, and many patients don't want to wait in the office. Again, there's no specific guidance given, but that's what our protocol has been here at our institution. A question that just came in is, for allergic asthma, do you see improvement with anti-IgE combined with subcutaneous immunotherapy? There was one study published about a decade ago that demonstrated that there was improved asthma-related quality of life and improved asthma symptoms when allergy immunotherapy was given in combination with anti-IgE, and it demonstrated the efficacy of giving both a broad, non-specific IgE-targeted therapy in addition to giving specific immunotherapy to specific allergens.
Okay. We do have a question typed in, and the question is, how do you explain or work up someone who describes dyspnea with speech? Cardiac causes have been ruled out. Dr. Buther, do you want to handle that question?
Yeah, sure. So this is a fairly common complaint, actually, and still have to go back to all causes of shortness of breath. But when someone particularly focuses on speech, you do have to also be concerned about alternative explanations other than something like asthma, COPD, or lower lung disease. And one gets a bit concerned about vocal cord dysfunction, and paradoxical vocal fold movement can sometimes cause cough or dyspnea with speech. But of course, any cause of dyspnea, be it asthma or heart failure, can be brought about by talking. I would just use this as a cue to maybe think harder about an upper airway process like VCD.
Next question is, what role do inhaled nasal steroids have in controlling nasal allergy symptoms? Dave?
Yeah, I think this plays a strong role. The nasal epithelium can become inflamed and often very similar mechanisms to the lower airways. And controlling rhinitis, be it allergic or non-allergic, is an important component of controlling symptoms of cough, as well as contributing to overall asthma control. And so I generally try to approach these conditions with my patients similarly about consistency and the parallels between topical corticosteroid use for rhinitis and for asthma, getting those two common comorbidities under good control.
Okay, good. Another question is, what's the role of testing sputum eosinophilia in determining targeted therapy? So eosinophilic asthma can be identified based on blood eosinophils, but it can also, and probably is better identified by looking at sputum eosinophils. Most laboratories have a hard time measuring sputum eosinophils or quantifying sputum eosinophils. There are some centers around the country, National Jewish is one of them, where sputum eosinophils can be reliably measured. If they're elevated, then they're helpful, and they may be even better than looking at blood eosinophils. There's been some cases, there was a case in literature actually by Mukherjee and colleagues at McMaster, where they identified people who had lower blood eosinophils but still had persistent sputum eosinophils. So I think that there's a good role for it. However, it needs to be measured in a reliable kind of way. Next question is, should a patient who presents with GERD or esophageal spasm and who complains of shortness of breath be evaluated for asthma, or can this be ruled out? Dave?
So absolutely. The issue is that oftentimes somebody presents with cough symptoms or perhaps episodic spasms of shortness of breath, and the differential includes asthma, it includes vocal cord dysfunction, it includes reflux, and oftentimes it includes all three of those things at once. This is a case that we would make, particularly in the adult patient, for objective testing for bronchial provocation with methacholine if they don't have reversible airflow obstruction on spirometry, and to try to sort out whether or not asthma is contributing. There's a whole other discussion about whether GERD can contribute to asthma or asthma can contribute to GERD or both. But the idea is to target rich environment and try to detect all of the different issues that can be causing symptoms and address them aggressively.
Good. Which patient would you send for bronchial thermoplasty? So bronchial thermoplasty, as noted, is a procedure that involves going into the airways with a bronchoscope, using a catheter that has a basket at the end that's hooked up to a heat source that breaks away the airway smooth muscle, the airway wall nerves, and plays a role in minimizing bronchoconstriction and airway hyperresponsiveness. I generally recommend this therapy for patients with severe refractory asthma. It's been shown to reduce asthma exacerbations in that patient population. The question has become, though, whether or not you should use this therapy versus one of the newer biologics. And it's a good question. There's no right answer. There have been no head-to-head studies, and they may have a complementary role. And so someone who has clear eosinophilic asthma, I would more likely in this era use an anti-IL-5. But if the person isn't responding, continues to have persistent exacerbations, then those are the kinds of patients that I may consider. Or if they have non-eosinophilic asthma, non-allergic asthma, those patients may also respond. That being said, it could be done instead of a biologic, and it's recommended by various sets of guidelines. What specialty do you refer to for workup of severe asthma symptoms that present? Dave?
Yeah, so I think this is really about your local care environment and what's available. And it's also to some degree about age. So in my mind, the older a patient gets, the more you might consider a pulmonologist instead of an allergist, because you start to think about many other comorbidities, including sleep apnea, COPD, interstitial lung disease, et cetera, et cetera. And we all would argue what is an older patient, but certainly somebody in their 20s with straightforward symptoms, but they're severe, might fit better with an allergist. Somebody who is perhaps 50 or older, and there are a lot of asthmatics out there that person might belong more with pulmonary in terms of comorbidities or atypical symptoms. But my pulmonary colleagues are hard to find around the country. Sometimes they're too busy in the ICU, in the hospital setting, they're hard to get into. And so I have found that in some communities, even older patients, their best option is an allergist, or in other communities, perhaps a pulmonologist is stronger. And so I think this can be very local. The key is to know your resources, know who you can get into and who can see patients and follow up regularly. But think about the age and the chance that they might have something other than asthma in terms of whether you want to really push for a pulmonologist instead of an allergist.
So that'll conclude our question and answer period. I want to thank you all again on behalf of myself and Dr. Buther for participating in this educational event. Thank you so much and have a great day.
This activity has been jointly provided by National Jewish Health and PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at www.peerview.com/JCQ. This educational activity is supported by an educational grant from GlaxoSmithKline.